Welcome, everyone, and thank you for joining us today for the latest session in the Donald Molony, MD, Dialysis Leadership Medical Director webinar series. I'm Kelly Brooks, coordinator for the Forum of ESRD Networks, and I have a few housekeeping items to go over before we begin. Next slide, please. First, please remain muted to minimize background noise and interruptions. You will have an opportunity to submit questions using the chat feature. You may submit questions at any time during the presentation, and we will answer questions at the end of the webinar. Today's presentation is being recorded and will be posted to the forum website for future reference along with slides. Next slide, please. A survey link to an evaluation form will be included in the chat and in a follow-up email you will receive after the webinar. We would very much appreciate your feedback. The Donald Molony, MD, Dialysis Leadership Medical Director Series honors former Forum President and current volunteer Donald Molony, who has dedicated himself to educating others throughout his career. Next slide. We have two more sessions coming up in this series. Tomorrow's session will focus on home dialysis and value-based care models with Dr. Daniel Landry. Then on June 23rd, we'll have our final session on how to effectively round in the dialysis unit with Dr. Deborah Hain. We hope you can join us for both sessions. Next slide. So let's get started. It is my pleasure to introduce today's speaker, Dr. Donald Molony, who is a professor of medicine at the University of Texas Medical School in Houston. He also serves as professor of medical subspecialties at MD Anderson Cancer Center. He is a past president of the forum and currently represents ESRD Network 14 on the forum's Medical Advisory Council. And I am happy to turn it over to you, Dr. Molony.
Hi, thank you very much for that kind introduction. This is just my conflict of interest. There's no conflict of interest relevant to this discussion. So today I really have two tasks. So one is something I really like to talk about a lot, and that is how one deals with natural disasters such as hurricanes and winter storms. But in the context of what we need to know as leaders in the dialysis facilities and keeping our patients safe, we really need to look at all the requirements that fall to the medical director in regards to emergency management and preparation therefore, and preparation for natural disasters. So I'm going to begin by talking about the conditions for coverage that define the required preparation and plans for response to emergencies for ESRD facilities. There's a whole special section on that. I'm going to review the scope of challenges from past hurricanes and winter storms, review the evolution of strategies to address patient needs and their impact on access to and delivery of emergency care. And then I'm going to identify some continuing challenges unique to hurricanes and other natural disasters. So I would hope that upon completion of this activity, you will be able to identify specific strategies to ensure dialysis treatment continuity using real-world examples when I talk later in this discussion about hurricanes and winter storms. Lessons learned from our natural disasters include, and this is just a high level that I want to emphasize now, and we'll come back to this at the end, importance of preparation, and this is also something that is specifically required in the conditions for coverage. Always prepare for the worst, not the best, and that is a lesson that we continue to have to relearn. Develop redundant means of communication that would be more resilient to down to power lines and or cell towers, and continue to improve our processes for protecting vulnerable patients. And this too is required by the conditions for coverage, namely that one should do an after event summary and determine what are the changes that may need to be made in order to meet the patient's safety needs. So I'm going to go over much of the conditions for coverage, and there are really three times that this was relevant to our discussion today. The first ESRD emergency preparedness and were defined in the conditions for coverage in 2008. And these required actions by ESRD facilities and were directed by and under the responsibility largely of the medical director. CMS also issued new rules in 2016 that modified these earlier rules and expanded upon them. And the last major update was in 2019 with the last modifications to this in the interpretive guidance in 2021. And we're going to go through some of these. I will note some that have changed, which were intended to make our ability to meet the CMS requirements, at least the paperwork of these requirements, easier to do. So this was from 2008. The VTAG that defined what this was all about stated that the dialysis facilities must implement processes and procedures to manage medical and non-medical emergencies that are likely to threaten the health or safety of the patients, the staff, or the public. The emergencies include, but are not limited to, fire, equipment or power failure, care-related emergencies, water supply interruption, and natural disasters likely to occur in the facility's geographic region. So if you're living in Chicago or in South Dakota, it's not likely that you're going to have to deal with hurricanes per se, but you may have to certainly deal with tornadoes and winter storms. The interpretive guidance covers emergency preparedness requirements of staff in VTAG 409, emergency preparedness for patient training V412, emergency equipment 411, emergency plan to obtain emergency assistance when needed V414. These are all VTAGs that designate these will be reviewed in surveys that are mandated by CMS on a regular basis to continue certifying that the facility is meeting the conditions for coverage. Now, I highlighted these last two because they have been modified. So V415, facilities evaluate and update emergency plans. And this was stated at least annually in the original work, but in the most recent iteration of this, it's biannually, that is every 2 years. And then 416, requirement for facilities to contact local emergency management agencies at least annually. So agencies are aware of the needs of the facility in case of emergencies. This has also been made into a biannual recommendation, and it's no longer required that the facilities document that they have had such contact. So steps to try to minimize the intrusion of paperwork, but also potentially limiting the ability of facilities to fully implement a robust, up-to-date emergency plans. That's an opinion on my part. So this was now 2016. This all came under the code, the ESRD part of the conditions for coverage 494.62. And this was designated as emergency preparedness. The link to a site where you can see these materials are shown here. If you just put that into your search, you should get to that document. The CMS, this final rule, establishes national emergency preparedness requirements for Medicare and Medicaid participating providers and suppliers to plan adequately for both natural and man-made disasters and coordinate with federal, state, tribal, regional, and local emergency preparedness systems. And this latter aspect, this coordination, has now been made into more of a recommendation, and much of the coordination ultimately will also be administered through the ESRD networks of your region, which are also required to be involved in your preparedness and your dealing with emergencies. They added details to the ESRD emergency preparedness, and then there were additional in the interpretive guidance E-codes that providers and state agencies would also be participating in. And then there were revisions to the E-codes in 2019 and added emergency. And one particular thing that was added was emergency infectious diseases to the definition of all hazards approach, which is the approach to any of these emergencies that are designated. This is actually was very timely because it occurred prior to the identification of the COVID pandemic, but allowed for the COVID pandemic to be one emergency that some facilities and networks participated in to try to manage. So the 2019 updates in the final rule, and these are two links to it, were intended to reduce the omnibus burden reduction or the burden of excessive work. The final rule removes Medicare regulations identifying as unnecessary, obsolete, or excessively burdensome, And the patients are over paperwork that they decreased the requirement for annual review of program to biannual, eliminated requirement to document efforts to contact local facility, local, tribal, regional, state, and federal emergency preparedness officials, and decreased training requirements from an annual to every 2 years to be commensurate with the also review of the plans. Now, in the next few slides, I'm just going to show you some of the specific items on this. It's not the comprehensive review of this. You can actually access these rules in their entirety via the form of ESRD Network's Medical Directors Toolkit under the Emergency Management chapter in that toolkit. Um, and they also informed an inclusion of a checklist that updated emergency preparedness interpretive guidance. This can be found here. And I'm going to go on to the next slides, the next few slides. So the E-codes required that there be an emergency preparedness plan evaluated and updated every 2 years, include conducting facility-based and community-based assessments and risk assessments should identify hazards using an all-hazard approach that is going to impact not simply a small unique item in the dialysis unit, but all the other related conditions that may impact the patient's safety and health that are related to that emergency. And it considers hazards most likely to occur in the surrounding area that would affect operations, including natural disasters such as hurricane, tornadoes, blizzards, and flooding, man-made disasters such as fires, active shooters, equipment and utility failure, loss of power, water, and gas, and interruptions in communications, including cyber attacks and EIDs with infectious disease emergencies. The plan should address staffing shortages, surge capacity, evacuation plan, services that facilities could provide in emergency, and succession planning. I note that these could be quite detailed. I would recommend that people reach out to their networks to obtain assistance in making sure that the important items of the emergency planning are spelled out and that they are trialed in the biannual run of these emergency plans. Continuity of operation planning needs to be included, including essential personnel functions and alternative facility identification and location if there is a shared management in the region of multiple facilities impacted by a major natural disaster. When reviewing for this, I was surprised to learn that the CMS recommendations or guidelines do require that all facilities have emergency generation of power backup. And that is not necessarily completely understood because there are regional and statewide regulations that do not require full emergency power backup for all facilities, but shared activities throughout the region. And that's what happens here in Texas, for instance. And these require processing for collaboration with other facilities and providers of care, but also with local, state, and federal officials in their efforts to maintain integrated response during emergencies. And this is where you see the two large organizations that are CMS contracted on the national level, the ESRD networks and the kidney CASER, which we're going to describe in just a bit. Implementation policies and procedures are based on the emergency plan, reviewed and updated every 2 years. System to track locations of staff and patients, medical documentation, emergency credentialing processes that are up to date and practical. Communication plans could include how facilities will coordinate with emergency management agencies and systems and must be reviewed every 2 years, but include specifically the names and contact information for staff, physicians, other dialysis facilities, entities providing services under arrangement, such as supplying water or power, generators, etc., local, in addition to federal, state, and tribal and regional emergency preparedness staff. So this is a lot of work, and it needs to be prepared and it needs to be tested through biannual drills. And CMS also recommends that these be reviewed on an annual basis, but not necessarily require a full drill every year. And there's, of course, needs to be training and testing and orientation programs, again, every 2 years, updating CMS conditions for coverage for emergency preparedness is based on the omnibus reduction bill that I already referred to. In years opposite to full-scale exercises, facilities may conduct second full-scale exercise or mock disaster drill or tabletop exercises as recommended by CMS. Document lessons learned following exercises or real-life emergencies and develop after-action reports which detail what is supposed to happen, what occurred, what went well, what facilities could do to do better, and what plan with timeliness for incorporating necessary improvement. And some recent publications in this area do demonstrate the utility of thinking about the response to emergencies, especially emergency natural disasters, using the primary healthcare disaster preparedness framework, which is a WHO framework. This would help, using that framework would help one interrogate everything that one is doing. There's a recent article on that in the International Journal of Disaster Risk Reduction in 2022 in volume 81. Dialysis facilities are part of an integrated healthcare system, and one should participate in unified emergency preparedness programs. Facilities still needs to show each individual facility actively participating in the program. Plan must address each facility's unique circumstances in terms of patients and population served and services offered. This is particularly important when one is considering patient populations in our dialysis facilities that may have more limited financial resources to be able to respond to requests for evacuation and other means of mitigating their or reducing their harm from the natural disaster. Each facility must maintain individual training records of staff and records of all required training exercises. This is, again, something that's reviewed by the reviewers. So the role of the ESRD networks in emergencies is key. They work with the dialysis facilities to track and report the status of facility operations. So if you have a hurricane coming up the Gulf Coast towards Houston, you may have 36 counties impacted by severe flooding and winds, but some counties would be less impacted. So knowing which facilities are open and which are reachable by our patients may be very important to their safety. And this is something that the ESRD network will take care of. That works with federal, state, and local government agencies as needed to assist the patient safety, prioritizing dialysis facilities to be open. And this actually deals largely with having resources from the local governments, power and water, that prioritize reopening facilities, dialysis facilities, at the same level as the hospitals. And your local network will contain emergency update pages that are readily available through the network and through internet, and other resources. Patient resources contained on the network may include patient communication plan, preparing for emergencies, resources for CASER and from CASER, and weather-specific response resources such as the extent of the hurricane, flooding, winter storms, extreme heat, tornadoes, etc. This all is great when it works in complete adherence to the recommendations, but communication, especially that which requires networking and electronic broadcasting, can be very haphazard during many of these storms. And we've learned that from our past experience. CASER, Kidney Community Emergency Response, is contracted to CMS, and it provides technical assistance to end-stage renal disease networks, kidney organizations, and other groups to ensure timely and efficient disaster preparedness, response, and recovery. The CASER program, disaster preparedness resources, help save lives, improve outcomes, empower patients and families, etc. CASER website contains resources for dialysis facilities, medical directors, ESRD networks, and patients. They updated information on CMS emergency preparedness rules, sample emergency management plans for different types of disasters, resources to help patients be prepared for emergency and respond during emergency, patient hotlines for from dialysis organizations and for dialysis organizations, and contact information for your local ESRD networks. All is great if it works. So I'm going to talk a little bit now, switching from that kind of long dialogue on what is required to just some of our responses to from our personal experience. And this is just a list of some of the major storms that have impacted the care of patients under my care here in the Houston Metroplex. Tropical Storm Allison, starting in 2001, was a major flooding event. And then, of course, Hurricane Katrina devastated New Orleans. And that was a key event not only for the nature and the extent of the disaster, but also for implementing and encouraging a more national response to natural disasters. Most of the 2/3 of the patients that had to evacuate from Louisiana ended up evacuating to Harris County here in Houston. Hurricane Ike and then Hurricane Rita in September. Got those dates backwards, but in September 2025, 2005 and 2008. And then Hurricane Harvey, along with Maria and Irma, all occurred in August and September of 2017, a very bad day or very bad month or two for winter forced hurricanes. Winter Storm Uri in 2021, and then Hurricane Beryl in 2024. The reason that I think it's relevant to look at multiple events is to acknowledge that even though we understood where we failed to potentially meet the needs of the patients as fully as we could have. The lessons were hard to remember or to learn, and very few people actually implemented the full nature of what we had learned from past storms. So that's one of the common themes. So development of disaster relief 1979, it's a long time ago, President Carter issued an order for creation of the Federal Emergency Management Agency, FEMA, in response to a request from National Governors Association. Bipartisan request. In 2001, the events of 9/11 highlighted a need for better coordination responses and more effective approach to incident management. This, of course, was not a natural disaster, but a man-made disaster. So President Bush, within days, issued orders for creation of what became the National Incident Management System, and NIMS, initiative under FEMA. NIMS creates the structure under which crises, large and small, can be effectively coordinated using people at individual organizations, communities, and regions. And then this was a satellite view of Hurricane Katrina, Monday, August 29, 2005. A lot of wind, a lot of water, a lot of rain, a lot of waves hitting the Gulf Coast of Louisiana. In response to Hurricane Katrina, which I'm not actually going to delve into all the failures that we are familiar with that occurred and that were identified by our response, I want to note that CMS convened a gathering of 125 individuals from all walks of the kidney community in DC to create the Kidney Community Emergency Response Coalition. Currently, the CASER consists of 7 work groups, and they're listed here, including, I should note, physician experts. So the CASER does attempt to listen to the providers that are dealing with these patients, as well as patients in their updating of their approaches. So then a rule was released from all this activity in 2016 that required that many changes be made, and providers and suppliers were required to comply and implement regulations by November 15th, 2017. This date is important because, as you note, the Hurricane Irma, Maria, and Harvey all occurred just before this date. So while the rules were released in 2016, they were not fully implemented by the time these hurricanes hit. So this is a satellite now of Hurricane Harvey. From living in the Gulf Coast, what I can appreciate is the coastal bend, and both Hurricane Katrina and Hurricane Harvey just kind of fit right into that socket and then head to our region. Recently, when investigating the natural disasters in this area, I came across a well-documented cited rather reference that there have been 82 named storms, tropical storms and hurricanes to hit the Gulf Coast of Texas since 1980. So we have a lot of experience with storms. Probably only other place that comes close is Florida. So this is Hurricane Harvey, one of the neighborhoods in the east side of Harris County, and there was extensive flooding throughout. This was just the rainfalls, in which you can see that that little dark green area. That's the Galveston Bay, and Houston is on the top of that Galveston Bay area, and the little line island is on the bottom is Galveston itself. And what you can see is that Houston accumulated between 40 and 50 inches of rain. The highest rain totals were in Nederland, Texas, to the east, for greater than 62 inches in a matter of 48 hours. So it's Hurricane Harvey tied with Hurricane Katrina as the costliest tropical storm cyclone, and it was the costliest storm till 2021 when Winter Storm Uri became more costly, um, and it was $125 billion in damages. And there were five major consequences of the mostly flooding. This was mostly a flooding event. It was not mostly wind. Direct health consequences to patients, inability to obtain medications lost to flooding and could not be refilled due to grounded mail order, which by that point, many patients were receiving many of their medicines through mail order, inability to access dialysis facilities, whether it was by the patients or by the staff that would be running the dialysis. And then, of course, inability of dialysis facilities and hospitals to provide full care due to inability to staff to travel to the hospitals. In our major teaching hospital, we ran 7 dialysis shifts a day, very shortened, and there were those of us who stayed in the hospital for 3 to 4 days continuously. And weeks-long disruption of clean water supplies and electricity that affected most of the freestanding dialysis units in the county. And this just also indicates that in this background, yeah, the ESRD network response to Hurricane Harvey dealt with the 18,000 dialysis patients in 260 facilities that were affected. Volunteers and network staff staffed the Texas ESRD Emergency Coalition Command Center, which I'll talk a little bit more about shortly. And they processed more than 700 calls. So the phone lines were still working for some of these individuals. They assisted patients in locating treatment options and placement, obtaining transportation, and providing resources. And the Texas ESRD Emergency Coalition is an example of the coordination between local, state, and federal organizations to meet the needs of a natural disaster. The TEAC is a partnership with the state regional advisory councils, or OEMs. There are 22 Texas regional advisory councils, or RACs, in 8 trauma service areas. And they all participated as members of TEAC and assisted in coordinating efforts during emergencies. And when this slide was written, very notably during the COVID pandemic, for transportation, emergency shelter, supplies, resources, and personal protective equipment for COVID, and reached out to the network directly to assist with patients placement and treatment locations. This is just some of the organizations that that were part of the that are part of the Texas Emergency Coalition, the TEAC, and as a good example of what state networks can do, or networks can do in a particular state to help manage natural disasters. And Texas, the TEAC was again a partnership, assisted in coordinating efforts during emergencies, and the network directly to assist with patient placement and treatment locations. And then the networks themselves also developed various online type of activities, such as the use of technology to help monitor patients and provide them with resources in real time. And a old form of technology that is also still a part of what most of the networks do is providing purple wristbands so that patients who had to evacuate had some identification of who they were and what their medical needs were. Now, one of the problems that occurred during Hurricane Harvey, but much less so in the more recent natural disasters, was the inability of people and providers to obtain access to electronic medical records that were outside when patients were showing up outside of their area of care. And this has been improved substantially through the resilience imported into the electronic medical record. And in the most recent disasters in Texas, at least, the large dialysis providers have all coordinated together to provide care to any patient that's dialyzed in any of their facilities, so that their needs can be met. The direct health consequences to patients of Hurricane Harvey, I'm going to just show you something that we did an analysis. The full analysis is still in final preparation to be submitted for publication, but there was an increased need to utilize emergency services. It wasn't quite as high as with Hurricane Ike or Winter Storm Uri, but it was still substantially above what was the background use of emergency services during that period of time. There was an increased presentations for hyperkalemia and increased hospitalizations, infection rates where the signal was not quite as clear. And the near term and long term, we're still evaluating that. And there was a possible increase in mortality. Preliminary evaluation of that is shown here, where we did see the spikes in the this is mortality occurring just at around the time that just as Hurricane Harvey hit, and beyond that for the next 2 months. The orange line is the Hurricane Harvey affected areas, and the blue line is non-Hurricane Harvey affected areas in the state of Texas, so they're adjacent counties. And the assumption that I made when evaluating this was that the care given in various counties in Texas probably was pretty closer to uniform than it would be comparing us to, say, New York or Chicago or wherever. So this did demonstrate clearly the increase in emergency visits, and hyperkalemia was the main reason for hospitalization and emergency care. So lessons learned from Hurricane Harvey. Unlike Irma and Maria in 2017, also in 2017, that mainly impacted Puerto Rico and Virgin Islands, Harvey did not cause significant wind damage to healthcare facilities. Extradialysis prior to the storm was spotty and insufficient. Power was out for much of 6 to greater than 10 days. Systems for rapid restoration of power were not in place to specifically service dialysis facilities. No dialysis facilities at that time had backup generators in the region. Backup generators are now required in the state of Texas, but only for the largest facilities. Clean water was not available for greater than 1 week due to contamination of the sources and supply systems. Trucked-in water served only a few facilities. And maintaining facilities intact with proper water and power, however, is not sufficient to provide care for patients, obviously, because having competent and sufficient staff is key as well. Transporting patients to their required treatment may present challenges, especially if boats or four-wheel vehicles are required. Medications and medical service supplies are lost in the storm and are difficult to reestablish. Impact of flooding on infection risk is unknown. And despite limited significant documented disruption in care schedules, some shortening treatments notwithstanding, these vulnerable patients may have demonstrated increase in mortality after the storm, and certainly higher need for emergency dialysis for hyperkalemia and hypervolemia. Management of these highly vulnerable population may require novel approaches and considerations, including if we can work out the kinks in it, the supplying of patients with a FDA-approved potassium-lowering agent binder that could be withstand hotter conditions and be viable for a long period of time. Contrasting Hurricane Harvey to now Winter Storm Uri, you may recall this was a winter storm that impacted all of the Southwest and all of the counties of Texas, including substantially both North Texas and South Texas. And it was anticipated, just like with the hurricanes, they're anticipated to last short periods of time and that everything would be fine and get dandy afterwards. And so getting patients fully dialyzed and prepared for the storms was not really as important because it was only going to last for 24 to 48 hours. It officially ran from the 13th to the 17th, but power was out for loss for 72 to 120 hours or longer, upwards of 7 to 10 days in some locations. Water outages lingered for much longer after power was restored, and dialysis facilities were not on the high priority list still in 2021 for power restoration. facilities with backup generators had fuel freezes because the diesel fuel that was provided to facilities in the warmer areas of Texas were not made to withstand freezing weather, and the fuel actually gelled and was not capable of feeding the generator. A key role for Texas ESRD Emergency Coalition in addressing Winter Storm Uri was also important. The other thing to note is that it was this is actually redundant, I think, mostly. It was a storm that there was a lot of cooperation between all the dialysis providers. This is just showing a fuel truck, a water truck rather, and then some of the destruction from the freezing of dialysis facilities that were, many of them across Texas were impacted tremendously by this storm. And one of our senators was caught flying to Cancun, you may recall. So lessons learned, significant benefit for broad cross collaboration between dialysis providers and sharing of resources, latter facilitated by the state and by ESRD network in collaboration with TEAC, getting caregivers into units, even in places that had power and water was a challenge. There were Jeep clubs and other resources, boats for the hurricanes, but in this case, large dump trucks, etc., transported providers to different hospitals as well as dialysis units. Instructions to call their home dialysis facility for instructions did not work, so providers improvised. Cell texting and paging services were largely inoperative for days, and systems to identify and inform patients were stressed and could not always identify status of patients. These are all things that, in afterthought, need to be further reformed and recovered. Hospitals were very stressed to provide backup when the water sources were failed. Dialysis facilities improvised. If they had power and no water, they used home dialysis machines. Few anticipated duration of the storm's impact, largely underestimated. As I indicated, as for the earlier hurricanes, we always underestimate the storm. We never overestimate what it's going to do. Contracted services could not deliver on water tankers and power generators. Survival packets did not include medications to reduce potassium, and shortening treatments prior to the storm left patients less well prepared for the subsequent loss of dialysis. Full treatments after 7 to 9 days without dialysis also problematic for some patients, and hospitals had their own challenges as backup facilities. So common themes, recent experience, people never fully anticipate the impact of the storm. Don't underestimate. Shortening dialysis to get everyone in has its cost. Transportation of personnel and patients is a problem in all of these storms. Electronic medical records may not meet needs of patients that need to travel for emergency treatments. Wi-Fi and other communication systems are very spotty at best. Dialysis depends on reliable water and power, which even hospitals might lack. Hyperkalemia is a common problem with missed dialysis for greater than 3 to 5 days, and mail order medications may not be delivered. Now, I've gone through these two storms and the lessons learned in large part because I'm hopeful that it will allow you to think about what you should try to anticipate in your planning for an emergency, in your emergency plan that you're required to develop for your facility. It should be individualized for the place and the geographic region of the facility, but anticipating that storms and other events may occur and longer than anticipated is very key to managing these well. Now, this does not actually allow you to be better at handling wildfires that impacted California in the recent years, where you might only have hours to evacuate or do anything else, or it doesn't anticipate things such as tornadoes or earthquakes. But they're all emergency natural disasters for which we should continue to teach our patients and our caregivers, our staff, how to be resilient and how to be improvised to make sure that everyone's safe. And the care packets that we give to patients that might include a potassium binder would work under any of those instances where there was a period of missed dialysis. Recent experience, people never fully anticipate the impact of the storm. Shortening dialysis, I think I've already gotten that already. Yes, I've already read through these. I don't know why I have repeat slides. And then final conclusions. Memory is short, and we seem to often need to relearn many of the same lessons over and over again. Emergency systems are not entirely reliable, and we need to depend on leadership and our own common sense to prepare for in advance and to address the unexpected conditions arising from a natural disaster progresses. Preparedness plans should anticipate common problems, have redundant mechanisms to address these problems. In particular, the redundant mechanisms for addressing the issues of communication, both to our staff and to our patients, and to provide for services to allow staff to provide the care for their patients. And with that, I will open it up to questions. I think we have 10 or 15 minutes for questions. This, just to give you a heads up, that's the backyard from our home in Santa Fe. So a nice moon that you can see rising above the mountains there. So questions in the chat.
Don't have any questions yet. Thank you so much, Dr. Molony, for that wonderful presentation. If anyone does have a question, you are welcome to put it in the chat, or since the presentation's over, if you want to take yourself off mute and ask, you're welcome to do that as well.
I've been accused sometimes of needing people to speed listen, so I hope I didn't go through that too fast.
No, that was fine. Great information. I did want to mention, and I'll put this in the chat, the CASER Coalition is now under the CARES contract. I'll put a link in the chat for that, but the contractor changed May 1st, effective May 1st.
And
So,
to say something about that, it's likely that the services CASER provided will be completely honored in the new with the new contract. That's their goal.
yes,
It just will
yes,
be different phone numbers and different contact people that you'll have to address.
right. That's exactly right.
And we
I
have,
just put a link in the chat.
okay. Okay.
Okay. Well, it doesn't look like we have any questions because you did such a great job of going over all of that
Either that or,
information.
yeah. So anyway, I
Thank
hope
you.
this is an enduring document and people can look at it and understand that the storms have taught us a lot. The rules actually that CMS requires make sense. And I think that most of the time, for many of our colleagues, that may be an afterthought trying to maintain those rules or think about preparedness. But it's really important, especially if you live in an area where there are different types of threats that could emerge, forest fire or hurricane or whatever. Thank you very much, everyone, for allowing me to participate in this webinar series. And I'm very honored to have been had this webinar series named in my honor. I don't deserve it, but I do think that it is a very important educational initiative by the forum, and we will continue to try to update it and to modernize it and have it available to anyone at any time. Thank you very much.
Thank you. Thank you, Dr. Molony. I'm going to share a couple of slides before everybody hops off. So I'm going to share my screen really
Do you want me to go
quickly.
through them? I think I
Yeah, if
have
you
them.
have them. Yeah,
Yep.
perfect.
I just said
Yes,
that
I
was the end
am.
of my talk. So a survey link.
Yeah, survey link is in the chat right now. You are encouraged to submit your comments and suggestions for future webinars. Next slide. You may not know this, but the Forum is a volunteer-led nonprofit organization with limited financial resources. So if you enjoyed this webinar and would like to see more content from the Forum, please consider making a contribution to our organization.
My hope is that little footnote is not going to impact that QR code. So I don't think so.
No, it shouldn't. It shouldn't. And last slide. Lastly, if you're not following us on social media, please do. You can help us spread the word about all the forum has to offer. We thank you so much for joining us today. We hope you will join us for our last two sessions in the series and have a wonderful day. Thank you.
Thanks.